So the test is really, well, the diagnosis is to take the history and examine the patient with a good, proper history, proper examination, and a good light, just to exclude any subtle skin problems, which should be visible. Yeah.
All right.
Oh, just worth mentioning the Q-tip swab, actually. I mean, that's sometimes talked about as the test for vestibulodynia. That's when you would use a Q-tip swab. It's a very poor test, actually, but it's one of the tests that's commonly used. We just use a Q-tip swab and we touch the area around the vulvar vestibule, the inner part of the labia minora, and that may demonstrate something called allodynia, which is excessive, a perception of pain, excess pain on genital touch, such as stroking, and that's a sign of nerve-ending pains. That is a test that can be done, which supports a diagnosis of vestibulodynia.
All right. So in terms of best treatment, best care for vulvodynia, what is that at the moment? How would you treat it successfully?
That remains an ongoing challenge. I think the first thing to say is that the individual needs of a woman with vulval pain and lichen sclerosis, lichen planus, and all the conditions that our sort of attendees have indicated they have, the needs vary because there is a spectrum of disease. There is a spectrum of very minimal symptoms. Lichen sclerosis, for example, can be asymptomatic in a very small number of women, but very symptomatic in others. Vulvodynia can, again, some women can have very minimal pain and function quite normally in society without complaints or impact on function, and then so that others will be disabled significantly by it. So in terms of accessing the best treatment, you're going to have to decide where the treatment options might be for that individual. So it's back to the assessment, isn't it? So ideally, we would have a history, an examination of the patient, and that history would be very detailed. It would look at the level of pain, the pain descriptors, burning, aching, rawness, soreness, etc. It would look at the impact on function, day-to-day life, working. It would be about social interaction, psychosexual issues, and then once you've done that very rich history, which I think takes on average a minimum really about half an hour to do. I mean, that is a luxury in the NHS, but it does take about half an hour to get all that information. And you can decide with the patient what you want to do, because I've got patients with very few symptoms, and I can offer them all of the treatments available, which are drugs, physiotherapy, psychosexual therapy. And some women will say, well, thank you, Dr. Nunns, that's fine, but at this moment in time, I will just have an open appointment. I'm actually self-managing, or any strategy that suits the individual is fine. So self-management is for some. Others will want to take everything that's available. And I think the challenges in terms of the best treatment is at least having that assessment and then having that discussion. We call it the shared decision-making process. And we talk about the pros and the cons, basically. And for example, amitriptyline, great drug, bad drug. But for some it's great, for others it's not great. But it's a conversation about the expectations of those drugs and how they work and their value. So that's the challenge, and we don't have that in the NHS at the moment, which is why we set up the VPS, because it hopefully enables women to look beyond their standard health professional to look at all the other options that we can talk about.
And let's talk about some of those treatment routes. So you spoke about amitriptyline there. One of the questions that has been sent in is if amitriptyline has stopped being effective in pain management, would you recommend trying other medications?
Yeah, I mean, when doctors, health professionals look at interventions in chronic pain, we try and look at randomized controlled trials. We have an intervention, a drug, anything really, cream, ointment. Take our group of patients, toss a coin, and then and one person gets the drug and the other person gets the placebo, and that's how medicine evolves. And we know that with randomized control trials in chronic pain, that the placebo effect or the dummy treatment has quite a high success rate. And a lot of the interventions, such as the drugs that we use, also have a high success rate. But generally, there may be something quite limited in terms of the benefits of the treatment. That might be nothing more than 50-60% of patients benefiting from it, as well as the high placebo rates as well. And those studies are often quite short term, so that long term we don't know what happens. And also with chronic pain, we've got some other options, haven't we? We've got the mood status of the patient, the level of anxiety, stress, other factors such as function, work, etc., that complicate the matter. So it's hard to pick out the drug as one drug being the best, as it were. So amitriptyline it's a very old drug. It's been around for years. It's prescribed for no end of chronic pain problems in general practice, and it does work for many women, but not all. And it doesn't. I wouldn't say it would cure the pain. It's not a curative treatment, but it may significantly reduce the perception of pain, the level of pain, potentially the number of flare-ups as well. What does that mean? It means that people may be more active, more mobile. They might sleep better. They may do things that they used to do routinely more often, so the function can improve.
Does that mean then, David, if the patient comes off amitriptyline, is there a likelihood that the pain might return, or would that be enough?
Well, we've always felt, in my practice up in Nottingham, and I think it echoes around the country with pain management teams, that the amitriptyline is only one of many strategies that a patient should try. So rather than the drug in isolation, you would try gentle exercise. You would try perhaps changing diet, setting goals, breathing exercises, pelvic floor rehab, all these other strategies together. So the combination is that you actually improve things. So what overall, we call it a sandwich of care. So you add things like a sandwich, and you add all these different strategies in to make this overall package. So the amitriptyline as a singled out intervention is difficult to unpick if all these other things are improving, because what you want to do is essentially shut down the central and the peripheral nervous system. From a pain perspective, you're trying to dampen down the perception, the feeling of pain, through reduced pain signal amplification. So if you're stressed and anxious and worried, the pain signal goes up because the central and the peripheral nervous system open up. Whereas if you're relaxed, for whatever reason, meditation, breathing exercises, whatever, mindfulness, then hopefully the pain, the perception is less through the central nervous system shutting down. So to unpick the drug is hard. I would say that the drugs, the amitriptyline benefit isn't an overnight thing. So you generally have to give the drug a bit of time to work if you're making a commitment to it. And I think that certainly more than a couple of months might be worth considering. So something that's within a month, it seems quite a short period of time for the drug, because you've got to escalate the dose to the level that suits the patient, and for it to work. And you've got to sort of manage to negotiate the side effects, which might be sort of constipation, etc. So I hope that's answered the question a long way round, but basically the drugs can work, but they've got to work optimally before they're stopped, I think. Often the drugs are given and they're stopped within a few days of treatment, and I don't think that generally is enough time for the day a drug's worked.
So at least a couple of months, really. And this sandwich of care, we'll dig into it a little bit deeper in a moment. Before we do, another one of these, another question that's come in: how can I get a diagnosis if the GPs keep giving me the same medications all the time, even if they don't work?
Yeah, this is difficult, isn't it? There is no accreditation process for a health professional to complete to be able to say, I can diagnose vulvodynia and I can manage a woman with a vulval problem. So, for example, cancer oncology is if you have a cancer of a certain part of the body, you are referred by a very defined pathway into a cancer team, specialist team. So, and that's very easy in many ways. With chronic pain, which includes vulvodynia, I would say that all health professionals involved with the management of women should be able to take a history and examine the patient and start basic treatment. And back to that sort of spectrum of women, some women have few problems, others have many. The more complicated women need to go to the specialist teams, I think. I would say in this question that you've given me, there's a concern that there is no diagnosis and there is treatment. Now, if that treatment, not sure of the detail, but if that's treatment for symptoms, that's sort of back to front. I would expect a diagnosis first. Vulvodynia, you've excluded all the other conditions we talked about at the beginning, skin disease, infection, and then the diagnosis is made and then the treatment is based on the diagnosis. I mean, that's good medical practice. That's what we should do. We don't tend to throw treatments one after the other at a condition which doesn't have a diagnosis. That's something we choose not to do. Mm-hmm. If there's no diagnosis, then ideally the individual needs to see a specialist. So the BSSVD has a website, British Society for the Study of Vulval Disease, and there is a list of vulval clinics there on that site. Now, I'm not suggesting everyone goes to one of those clinics, because we can't endorse those clinics as being a clinic that will give you what you need, because they're all different clinics, but that's a start. It may be worth asking a health professional for another opinion if you haven't got a diagnosis. Yeah.
Right. Okay. And how would you go about getting a referral, perhaps to a clinic or a multidisciplinary team? Should you self-refer to one of these clinics you're talking about on the BSSVD site, or would you need to go through the GP?
Good question. So let me tell you about the clinics first of all. So the clinics are run by gynecologists, dermatologists, sexual health doctors, GU physicians. They may be run in isolation. They may be run as what's called a multidisciplinary clinic, where there's two individuals in the room. So, for example, some of our listeners have got lichen sclerosis and lichen planus. So those are skin conditions, and lichen sclerosis, we're estimating around up to 3 in 100 women have that, so it's not uncommon. And lichen planus on the vulva, but perhaps slightly less. So a dermatologist stroke gynecologist, you might think is the right person for that individual, and that's true. A lot of GPs, however, will manage lichen sclerosis quite effectively. And similarly, vulval pain, you might assume that a pain specialist is the person that you need to see. Well, again, vulvodynia is, I think we've got a background rate of pain, a lifetime risk of something like up to 16%. It's very common, vulval pain. Again, we can't expect these clinics to see all of the women with vulval pain. So it's a sort of distribution of care across the whole of the health professionals, and the clinics are quite concentrated and probably should be dealing with the more complex patients. Things haven't settled. So you can ask for a referral to the hospital, vulval clinic. You might get referred to general gynecology, general dermatology, or sexual health. Sexual health have a very valued resource where you can walk in. You essentially can walk in. So if you think you've got thrush or discharge or something, you feel it needs an acute referral or an assessment, most have a walk-in service, and the doctors there are of great value, and the nurses, and you'll get a history examination, swab, and then often they will do the microscopy or the microscope examination there and then. So that's a sort of walk-in service. Half the patients I think that they see don't have sexually transmitted diseases. The other half do. So that they deal a lot with people concerned about sexual health. GPs might be referred to not to the sexual health clinic, but to gynecology, dermatology. So that might be worth asking a GP for referral. It's an ongoing problem in terms of access in these clinics. As I say, they're very variable. Accessing an MDT, a multidisciplinary team, that's not generally what would happen, but you go into a clinic and then some of the clinics would have a multidisciplinary team, right, who would then discuss your case from a team perspective and then decide what that individual's care plan, might call it, would be. Do you need to see the physio, sex therapist? Do you need to see CBT therapist, etc.?
Okay. Can we talk a little bit about topical treatments? And if we start with perhaps thrush to begin with, there's someone has asked, my problem started after an intense course of thrush treatment, and the skin is consistently raw. It's never been the same. Are there thrush treatments that don't make vulval pain worse?
Yep, common issue, isn't it? Thrush. I mean, thrush candida is a yeast commonly present in the vagina, vulvovaginal area. I suppose the big question is it a misdiagnosis when it is picked up? Is it a red herring? If you think that thrush is commonly present in the vagina and you've got symptoms, if you pick the swab up, if you take a swab and you pick thrush upon a swab, is it truly relevant, or is it just a fact that 1 in 3 women have thrush in the vagina? Generally, by and large, thrush candidiasis is when there's too much of it, causes irritation and discharge. So it's an irritation, itch, primarily leading to secondary pain and discharge. So, and I think that's the classic attack that GPs often see. And then it's treated and it goes. So for a woman with persistent vulval pain, in the absence of the irritation, the discharge, who's got thrush on a swab, but the question is it relevant? Is it something else? Recurrent thrush is more than 6 attacks a year, but these are usually quite finite finite attacks of thrush that tend to respond to antifungal. I mean, that's the point really, because that's an important point, because Candida yeast usually responds incredibly well to antifungal. So we talk about sometimes drug-resistant yeast. It's not very common at all, that. So I think that taking self swabs, that's what we do up in Nottingham. We give swabs to the woman to take herself. She takes them when she's symptomatic, puts them in the packet and sends them into us, and we process them. And if all the swabs were positive over a period of time, then that may have some relevance, and we would treat with a sort of maintenance dose of antifungal, Diflucan, or the over-the-counter products that you can get, antifungal treatments. And more information on that is from the NICE guidance on recurrent thrush, NICE guidance on the website. And there's a good, clear regime that GPs would follow. And if all the swabs are negative, then you think, well, actually, is it thrush? And we might have to reconsider that thrush isn't the problem. Again, all those studies have been done in the past where people have taken biopsies and looked at microscopically for any hidden yeast, and it's not shown any, because the Candida that is so easily grown on a swab. Yeah, it doesn't lurk under the tissues and that.
Okay, all right.
I guess one thing to say, sorry, Sheren, is that Canesten creams and pessaries may potentially be irritants on the skin if that's sensitive. So we tend to go for oral treatment. Yeah.
So you would go for antifungals?
Yes. Yeah.
So in terms of creams for dryness and extreme sensitivity, what would you recommend creams wise for the vulva?
So just as a rule of thumb, genital skin is it's more prone to skin conditions than other surfaces of the body. It's more prone to drying out because the skin is thinner than elsewhere. When I say thinner, anatomically thinner, genital skin is, penis, vulva. It is a sensitive skin surface. And also very relevant is that for women who have gone through the menopause, there is the additional lack of vaginal estrogen. And that might compound some of the issues we've talked about, pain and irritation. So I think these are what we call physiological factors in the skin that make it a special sort of skin surface. So as a rule of thumb, when you've got symptoms, the blander the better. So scented products, over-the-counter products have a lot of hidden scent in them. So all the baby products that you might assume are low allergy do have hidden scent. So the blander the better. And if there is dryness, then a moisturizer is fine. What's the best moisturizer? Well, it's the one that an individual will use. So there's no true one superior moisturizer, except the ointments, which are greasy, tend to be better than creams that are less greasy but easier to apply, and they're better than lotions, which are very easy to apply but don't last very long. So ointments, yes, worth a trial, bit of trial and error, which is the best one. Aqueous cream you can put on, but you have to take it off because we tend to take, it's got something called sodium lauryl sulfate in, which can irritate the skin in some individuals. So ointments are worth considering. Obviously, it's a core treatment for LS and LP. Estrogen replacement, if you've gone through the menopause or going through the menopause, again, very safe in terms of pessaries. Estrogen creams can be irritating. Worth a go, though, in terms of trying to reverse vaginal atrophy, if that's there, or lack of estrogen. Other than that, I mean, we give steroid ointments to lichen sclerosus, steroid ointments to lichen planus. the other things for vulvodynia, vulvodynia and vestibulodynia are anaesthetic ointments and gabapentin gels. There aren't hidden creams available that we are using that are top secret that we never share or we can't get hold of. Those are by and large the commonest things we use. As I say, we shy away a lot from topical treatments because the skin's so sensitive. So, yeah.
Someone has asked about topical gabapentin on the NHS, how to get hold of it if the GP doesn't know about it.
Yeah, so gabapentin gel, yes, gabapentin, a pain modifying drug. It's been around for a long time. That gabapentin gel, it's a topical treatment applied to the area of pain. I gather it's made up in St Mary's Hospital in Cardiff by the pharmacy department there, and it may need a bit of detective work to try and enable that prescription. It was in the past very expensive, but I think it's come down in price now, and it lasts longer. Twice a day, given, applied to the vulval area, avoids the systemic side effects that you might receive with a tablet in gabapentin form. In terms of evidence, good clinical trials, it's with no randomized trials, but perhaps they're going to happen at some point. But yes, St Mary's Hospital, Cardiff, might have to ask the GP for a prescription. If not, email us at the VPS, and I think we've had this inquiry a few times that we can sort of point people in the right direction. I'm sure. Yeah.
Great. And you mentioned estrogen replacement pessaries. Does that mean hormone creams are safe to use if you have LS, Vulvodynia, Vestibulodynia, LP?
Again, good question. So they work for many, for not for all, and they are licensed predominantly for genital atrophy following the menopause. So dryness, irritation, symptoms during and after the menopause. We wouldn't normally give it to a premenopausal woman because the estrogen levels should be normal, having normal ovarian function. So it's these symptoms develop after the menopause. So there is minimal absorption of these drugs when applied topically or in pessaries. So Vagifem pessaries are pessaries that are delivered nightly for 14 days into the vagina and then twice a week maintenance as at least a 3-month course. It's said that a year's worth of this treatment is equivalent to 1 tablet by mouth of estrogen. So my point is that even though they are a hormone, there is very little general absorption. So in Nottingham, where I work, we give the treatment to women who've had breast cancer, for example, where even if they have an estrogen receptor positive breast cancer, we still give them estrogen pessaries and creams. So they're quite safe. And so I think it is a trial and error treatment if you've got a vulval problem, but even it's worth having a conversation with the doctor about having them if you're peri or postmenopausal. Yeah.
And I know that on the webinar today, there are a number of women with LS and LP that have joined and also registered to receive the recording of the webinar. And just to let everyone know that next Friday, the 17th at 2 p.m, we'll be running another Q&A with more of a focus on those areas of lichen sclerosis and lichen planus. So we can dive a bit deeper into those areas. So for today then, can we have a chat about physio and the pelvic floor side of things, the pelvic floor muscles? One of the questions that has been asked by a number of people is about tight pelvic floor muscles. Is it a massive cause of pain?
Well, I suppose, yes. I mean, the big change over the years is the integration of physiotherapy, women's health physiotherapy, into the multidisciplinary team managing women with vulvodynia, particularly difficult vulvodynia. And actually, we talked about LS and LP. I see someone's got pudendal neuralgia. There are sort of overlaps with those conditions because the pelvic floor response to pain can be to shorten and tighten the muscles. Mm. So the response to pain is to protect over a period of time, perhaps over 3 months or more. The response is to shorten and tighten the muscles, and this in itself can, you might call it, perpetuate the pain cycle. Yeah. Mm-hmm. So somebody has 3 people have got vaginismus as well. I mean, that's there's a bit of blurring of the lines here. We can't. Doctors like things in compartments, and they like to have very fixed thinking with a lot of things in medicine. And I guess patients do as well. We like to think about things in different compartments, but actually pelvic floor transcends all these diagnoses, I think, and has great value in terms of at least having the pelvic floor muscles addressed. But the muscles are a complex set of muscles. They are essentially a very dynamic muscle that moves all the time when you open a bowels and pass water. They change with intercourse and arousal. And there are lots of different muscles wrapped up individually in their own fascia or their membrane. And we don't truly know whether it's the chicken or egg. Does the pain in the vulva lead to a tightening of the muscle, or does the tightening in the muscle lead to the perception of pain in the vulva? And I suspect for some women with vulvodynia, it's a bit of both, really. Now we've got vulvodynia as a wide group of women, as I mentioned. There are some women who've got largely central processes going on in the brain. Yeah, so there's the central sensitization. These are women who've got lots of other pain syndromes, temporomandibular joint problems. They might have irritable bowel syndrome. They might have other painful mouth syndrome where they get sore tongue. So there is a problem with the pain center in the brain. And there are other women who've got peripheral nerve problems in the skin, the Vestibulodynia patients. The problems are on the skin. And then there's this other group of women with pelvic floor muscle problems. Where are the clues? Well, is it a muscle problem? Well, sometimes in the history, there may be a history of childhood problems passing urine. Yeah. So if the pelvic floor has been tight for years into adulthood, it may be that the bladder doesn't come out with a good flow. There might be drips and drabs when you have a wee. You might be getting up several times a night. It may be that you have a good wee and then you think the bladder's empty, and then 20 minutes later you've got to nip to the loo again to empty it again, and that's a sign of incomplete bladder emptying. So those are the clues in the history. Constipation as well, very bad constipation over many years, might be pelvic floor related. And so when a pain syndrome comes, vulvodynia, for example, it's very important to just at least have an assessment of the pelvic floor by a physio, not a sort of a rugby playing musculoskeletal physiotherapist called Bert, who's never seen the vulva. But we're talking about a woman's health physio and a woman's health physio with an interest in pain, a pain assessment. And there's the Squeezy app on this Squeezy, which is on, I think, our website, which is an NHS supported physio finding app or website where you can tap in your postcode, mention not specifically so much bladder weakness, but pain, and you might get directed to the right person. So that's quite a good resource, because it's not It's not weakness. It's different to a weak bladder. The muscles are too tight.
Okay. How are you spelling squeezy?
I think it's Squeezy.
All right. So, okay. So there's no
Is it a word?
particular
It's
squeezy.
yeah.
Okay, squeezy out. All right. So I'm mindful that we're getting on in time, in terms of time. So we've got some nervous system questions, which I think you really answered and covered before. The questions were to do with how do you calm down the nervous system without antidepressants or anticonvulsants. And you mentioned mindfulness, diaphragmatic breathing. Anything else you'd recommend on those fronts to calm down the nervous system?
I guess over the years working with the team at the VPS and speaking to patients, there are so many different strategies. So just off the top of my head, let's take away the drugs and the physio and formal psychosexual therapy. Women are saying to me, I read, I do yoga, I go for a run, I've tried acupuncture, I've got a TENS machine that I use that I bought over the counter. I've changed my diet. I don't drink alcohol as much. I changed my partner. I changed my job. There's the whole thing. There's a whole mixture of rich individual experiences that you wouldn't see in a medical journal that led or paid that contributed in somehow, however big or little, to that woman getting better. I mean, things that stick out are exercise. Actually, I have to say that the sort of the gentle stretches that Amy Stein's book, which is on healing pelvic pain, I thought it was a great book because it just suddenly introduces, for many women who are quite disabled by the pain, the concept of gentle exercises. I mean, those are things that are worth trialing, really, because I think there's value. And I mentioned acupuncture for unprovoked pain, not for vestibulodynia, but these are things that might help. Okay. The research is quiet though, Sheren, at the moment. There's not a huge on the internet in medical publications. It doesn't have that sort of information in published studies.
And I imagine that would be the same for things like Botox and the Mona Lisa treatment, things like that too. That the evidence isn't there yet.
You're absolutely right. The evidence isn't there. The Botox is again an age-old treatment used largely for migraine, overactive bladders. It's used in chronic pain clinics a lot. It's a poison, and it relaxes muscle. Lasts for 3 months, and it's given as an injection. And it does seem to have some benefit for tight pelvic floor muscles. So for someone who's had an injury, for example, or maybe that's a postnatal issue, and they've got a tight, short pelvic floor muscle, levator muscle, we call that, and it's a very specific knot of muscle, you might call it, or tight band of muscle, then the physios can feel, and the Botox injection probably works. There's a few studies injecting it into the skin, not the muscle, the skin in women with provoked vestibulodynia that you can read about on the internet. And those were published last year. If our listeners want more information on that, we can talk about that again. But there's a couple of papers that talk about Botox, but they're not randomized controlled trials where we toss a coin. You mentioned the Mona Lisa therapy, which is licensed, I gather, for atrophy after the menopause, vulvovaginal atrophy, lack of estrogen. It encourages the skin to change in texture and be less atrophic, and produces improved symptoms through a process of a laser treatment. It's CO2 fractionated laser outpatient treatment. That's not shown to be a value in chronic pain. So I would not suggest it at this moment in time, although maybe that's a treatment option. Same for LS and LP.
Right.
There has been some concern that it is not of benefit for patients. So at this moment in time, perhaps to be mindful of the fact that treatment is not shown to be working for all these conditions. But that might change with clinical trials that may be set up in the future. Yeah.
So to wrap up, David, and I'm mindful that we haven't got through all of the questions, but we have got through the vast majority of them, or certainly touched upon them. And as I mentioned, next week we will have another Q&A to cover any of the questions we didn't answer and the opportunity for more questions to be asked. In your experience, David, when a woman has this sandwich of care and they've identified all the different elements that might be useful, will that patient generally be able to return to a good quality of life? So in terms of healing, getting back to doing the things that are important to them?
Well, I'm very hopeful that the vast majority of women can get back to an improvement in their function. What is function? It's everything we do day to day, isn't it? Putting our clothes on and brushing our teeth and doing all the things that we would hope to do as part of being a citizen of our society, going out of the house, and that doesn't include function, includes working potentially. For most of us, we have to work. So an improvement in function, a reduction in symptoms, sort of less pain, less discomfort, to a level where symptoms have either gone or are manageable. And then also this issue of self-management, and that an individual would know what the triggers are, what causes a flare-up, and can this be avoided. So that's relevant to LS, LP, Vulvodynia, and also, I guess, an element of happiness attached to that, some impact on mood, because all that may be there and may be improving, but I guess mood and how you feel is all crucially linked to the whole package. So those are the outcomes we look at. I had one patient, she was desperate to work. I mean, her outcome that she really wanted was to work because she needed the money, and Vulvodynia had stopped her working. So with low dose amitriptyline, the pain went from 8 out of 10 on a pain scale down to 5 out of 10, and that was enough for her to begin to work. So her pain was 5 out of 10. It wasn't 0 out of 10, but the outcome for her was that she could work. So that would be an improvement for that patient, not perfect. So I would say in our practice, I would say perhaps more than 7 out of 10 women have quite significant improvement in their overall experience of their pain with that sandwich of treatment. Lichen sclerosis, lichen planus, perhaps a little higher even than that, but it's not 100%. So, but I'd like to think most of them are going to do. Most of the women are going to have some improvement, small or significant. And I see people many years down the line, and they are getting better, or they've adapted slightly to their pain. And so living in Nottingham in East Midlands, there is a fairly stable population, and I think I don't think we see. I see quite a stable cohort of women who most of whom have an open appointment. I mean, it might be true that we just don't know what long-term things are for many of the women, because I'm sure they get fed up of seeing me sometimes. But I mean, they do have open appointments and that. Some like to come for a yearly checkup just to see how they're getting on.
Mhm.
But most are doing all right.
Good, good. Well, I think that's a nice note to wrap up on. That a significant number of women, 7 out of 10, do notice that change, or a significant change in function. And I hope that for everyone watching and listening today, that that's been helpful, that the questions that you're able to answer today have given more hope and some kind of direction or guidance as to next steps and accessing the best route towards care. And hopefully we'll see you again next Friday, the 17th at 2 p.m. We'll be sending out an email with a link to the webinars that we've recorded. We did have some technical issues at the beginning, but we've captured most of it. And there will be the chance to sign up for next week as well. Any final words, David?
Oh, just to say that, yeah, keep the questions coming, and if there's anything that, you mentioned the deep dive. Yeah, absolutely. If you've got a question and you think that we should, if there's a theme coming through and we can really dig deep into a specific area, well, let's do that then. I think what could be an outcome from this is that we do put more information on the website, and we might even have some homework to do to come back to cover this at a future webinar. So I think it's a good opportunity now, especially with shutdown in our country. Yeah, so it seems the right time to do it.
Good.
I'm mindful that a lot of gynecology services, well, just all the elective surgeries in hospitals have been cancelled, and literally all the vulval clinic appointments, I'm sure, and pain appointments and skin appointments have just simply been cancelled until the pandemic settles. So that there may not be a lot of face-to-face consultations for some time now. So that's why we decided to do these webinars, didn't we, Sheren?
Yeah,
just
absolutely.
try and not fill a gap, but just at least perhaps provide some continuity of information. Yeah.
Absolutely, yeah. And the email address is
info@vulvalpainsociety.org.uk.
Can email with any more questions, and absolutely, as David says, if we get a theme coming through, we'll run a webinar or a Q&A in future. The next one is next Friday, the 17th at 2 p.m. Hopefully we'll welcome you then. Thank you, Kay. I know you're there in the background dealing with any technical issues today, and we'll see you all back here next time, hopefully. Thank you for joining us. Bye for now.
Thank you.